Surgery really progressed in the mid-1800s when anesthesia was discovered because they could do these radical surgeries without the patient being in excruciating pain. Something that's dear to my heart are the advances in rehabilitative plastic surgery. The use of free flaps, the use of CAT scans to model parts for replacement, I think has made a tremendous difference in the quality of life of our patients. Early recovery after surgery programs or protocols have increased patient outcomes for the better. And a lot of this involves nursing doing education with patients and families before surgery and what we call prehabilitation, getting the patients in the best physical shape possible before surgery.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Deena Dell, Nurse and Professional Development Specialist in Oncology at Sarasota Memorial Hospital, Brian D. Jellison Cancer Institute in Florida, to discuss the history of surgical oncology, how it's evolved in recent years, and what we can expect in the future of the specialty. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, Deena.
Thank you for inviting me.
So let's start by going way back in history. Before we knew about systemic or radiation therapies, the only way to treat cancer was to physically remove it. What did surgical oncology look like back then?
Years ago, I think surgical oncology was actually pretty barbaric. In 3000 BC, we actually have notes of Edwin Papyrus describing 8 cases of breast tumors that were removed by cauterization with a tool called a fire drill. In the late 1700s, the idea was posed by John Hunter that some cancers might be cured by surgery if it had not invaded nearby tissue and was movable. And note, if it had not invaded nearby tissue is important because that's the only consideration they gave it. There was no belief that cancer could spread through blood vessels or lymphatics. Surgery really progressed in the mid-1800s when anesthesia was discovered because they could do these radical surgeries without the patient being in excruciating pain during the operation. And as I said, they believed the cancer would be more curable if it was radical. And the first surgery was Halsted, who we all have heard of the Halsted radical mastectomy. In 1890, Dr. Halsted performed that first surgery. And I started my career as a medical coronary ICU nurse, not an oncology nurse, not even a surgical nurse. But in the mid 70s, I started teaching nursing school, and my first experience with cancer patients were women with breast cancer. And at that time, biopsies were not done. These women, I remember vividly their fear because there was a lump in their breast. They were going into the operating room, not knowing if they had cancer or not. And when they woke up, they would feel to see if they had a breast or not. And they all had radical mastectomies. It was pretty depressing. We said in 1890, that's when Halsted started doing the radical mastectomies. By the early 1900s was the real beginning of cancer surgeries. The first radical suprapubic resection was actually done in 1904 by a Dr. Young, the first radical hysterectomy by Wertheim in 1906, the first abdominal perineal resection by Dr. Miles in 1908, and the first lobectomy was done in 1912. Modern surgery today has changed tremendously because we now realize that cells metastasize by the blood, by the lymphatics, do not just spread locally. and were able to do less drastic surgery and use systemic treatments.
It truly is amazing when you listen to that history, what happened, in those very, very early days of surgery and how those surgeries were done. And like you said, how barbaric they were. But can you tell us what was the nurse's role in those early, early, early stages of surgery?
The nurse was not considered very professional at that time. They were more like the mother. They did bedside and comfort measures. They would clean and dress wounds as best they can. The role of the nurse was an arduous one, and it was thought of as being depressing and dangerous, especially with cancer. The thought was that the cancer could spread and was contagious, and most of the patients died, which made it very depressing. When World War I came around, the role of the nurse started evolving as the doctors and men went to war. So nurses took up more technical abilities roles. In addition to giving emotional support, they were knew to look for signs and symptoms of infection, wash hands. They even started doing venipunctures and things like that.
Great. So, like you mentioned, it wasn't until the 19th and early 20th centuries that advancements were really made in surgical oncology. Can you touch on what some of those advancements and milestones that helped surgical oncology get to where it is today?
Well, to me, some of the very important things are tissue biopsies. We started using non invasive biopsies and imaging tests to replace exploratory labs and trying to diagnose cancer and see where it spread. We did a lot less invasive surgeries. Around 1970, the first, I believe, clinical trial was done showing that breast conserving therapy plus radiation had the same positive result as mastectomy. We learned to remove less bone and avoid amputations. We learned to avoid colostomies for patients with rectal cancer. Initially, everybody with the AP resection ended up with an ostomy. And then, of course, laparoscopic and robotic surgery came into being. We have the laparoscopic colon and abdominal surgery. We have video thoracoscopy for the lung. We use endoscopic surgeries to remove tumors in the colon, esophagus, and bladder by entering the body through natural openings. We started using radiofrequency ablation, radiosurgery such as a cyber knife. We can do laryngoscope laser surgery for the cervix, larynx, liver, rectum, and skin, cryosurgery, and probably the Da Vinci robot, which is allowing us to do 3D tactile surgery in a much less invasive way. And something that's dear to my heart are the advances in rehabilitative plastic surgery. The use of free flaps, the use of CAT scans to model parts for replacement, I think has made a tremendous difference in the quality of life of our patients.
So, Dina, there were a lot of advancements that were made, as you mentioned, in the 19th and 20th centuries. How has that role of the nurse also been involved in those developments?
Well, 1940s, we developed standards in oncology, which makes patient care and nursing care a lot better because we actually use evidence to tell us what to do. Nurses always, though, have made their contributions because they've learned to be situationally aware, they know how to critically think, and they make complex decisions. The surgical nurses have to continually assess symptom burdens, psychological needs. They have to assess the environment and what's going on, and they have to interpret subtle changes in their patients. They have to learn to interpret diagnostic data and then use the scientific basis of their training to make decisions on how to alter patient care. Another big contribution nurses have made is in early recovery after surgery programs. Early recovery after surgery programs or protocols have increased patient outcomes for the better. And a lot of this is involves nursing doing education with patients and families before surgery and what we call prehabilitation, getting the patients in the best physical shape possible before surgery. So different programs have different prescriptions. They might tell the patient you have to walk 40 minutes a day, every day before surgery. They can work on controlling diet and glucose. We no longer keep patients MPO for after midnight. We ensure they get enough carbohydrates so their electrolytes and blood glucose remain more normalized during and after surgery. We try to get tubes out faster to prevent infections and restore normally body functions. We try to get patients eating faster, and we have to learn to manage pain with the use of less opioids because of the problem of opioid addiction. So we've learned to use multimodalities in dealing with surgical pain.
So interesting to hear about those early recovery programs, like you mentioned, just the improved outcomes and thinking about all the ways that surgery used to be done and how long those patients used to be in the hospital. And, thinking about even family members who think, oh my goodness, you're sending them home tomorrow and they just had their surgery a day ago or a day and a half ago. But when you do incorporate that prehabilitation and the better teaching methods and things like that, it really does have a much better outcome for those patients. And it gives them that autonomy and feel like they have more control over their care and their recovery when they're involved that way. And they know, okay, I can go and walk for 40 minutes, like you mentioned, a day. And if I do that, that is going to, increase circulation, increase my resilience and, at my stamina and just all of those things that definitely help in that recovery mode for patients who are having surgery.
Most definitely. And when you show patient the statistics that they will go home sooner, they'll get back to their normal life sooner. A lot of patients are afraid to take narcotics. I know even in the 80s and 90s when I was working in the intensive care, patients say, no narcotics, I don't want to get addicted. So they're very happy that they have other alternatives for pain meds. And a lot of these other alternatives cause less sedation, less constipation. And the to do this involves a lot of nurse education of the patient and family to make the program successful.
So important to have the nurses involved at that level and ahead of time. And also just the multidisciplinary team and those other disciplines that you bring in with the ERAS programs and having physical therapy involved earlier and nutrition involved earlier and things like that. I think it's just a really amazing piece of how surgical oncology has evolved and improved over the years.
Right. And I guess I should have mentioned that the oncology nurse has a large role in working with all these disciplines and making sure they all work together, coordinating care.
Exactly. So I want to ask you another question, and this is about clinical trials. How has that affected surgical oncology over the years?
Clinical trials in surgical oncology have given us better treatments, often less invasive treatments. Like clinical trials, for example, with breast cancer showed that a lumpectomy and radiation had the same outcome as mastectomy. And with that information, patients were more secure in choosing lumpectomy and not feeling that they had to lose their breast if that's what they wanted. I have found out working with breast cancer patients that some want the breast off, but for those who don't, they have that security. We've done surgical trials using heated chemotherapy along with surgery, less invasive surgery in other areas. And what we do is compare the new approach with the standard approach and prove that it's equal or better so that we can give that information to the patient. And oncology nurses can be involved in the clinical trials in many ways, depending on what their role is. They might be involved in recruiting patients. They may be the person who educates the patient as to what the surgical trial is and supplies a lot of the education to make sure the patient gives adequate informed consent. They're the care coordinator sometimes between different disciplines. And of course, the nurses who are caring for the patients need to monitor and report explicit outcomes.
Thank you for explaining how the nurses are involved in that. I think they definitely play a very important role in clinical trials and making sure that things are kept on track with trials and so that they will have the results that we want to see coming from those trials.
Correct.
Can you talk to us about how the field of surgical oncology has evolved over your career and how your role has changed in that?
Well, I think we've touched on a lot of the developments in surgical oncology. My role has changed. I worked as a clinical nurse specialist in an NCCN Cancer Center critical care unit, which was mostly surgical patients. So I had to make sure that I knew what the new surgery was, what it involved, what new risk it posed, what new side effects, and what the appropriate nursing care should be, and educate the nurses that I worked with as to such. Also, we had to learn a lot about information technology as far as charting, recording, using different devices to help us give patient care.
It's interesting as you've mentioned how just surgery has changed, but listening to how you've mentioned the role of the nurse has definitely changed over all of those years and how they're really becoming a much more prominent and involved role with surgical oncology and an important part of making sure that patient outcomes are improving and having better success.
Correct. I think of things like even before early recovery protocols, we learned that we had to monitor blood sugar carefully. So that was a whole new thing, the glucose protocols. We had to learn how to autonomously adjust the amount of insulin patients were getting when they were on insulin drips. We now have artificial intelligence smart machines that do that for us. We just put in the data and they tell us. But when I left surgical oncology maybe 7 years ago, we were doing all of that by hand using math calculations. We also started using things like targeted temperature management for our patients who coded after surgery to make sure they had the best neurologic recovery. So, a lot of things that you wouldn't necessarily think of as surgery, surgical oncology nurses have learned to do.
Exactly. So I want to switch gears a little bit. And you mentioned earlier robotic surgery.
Yes.
Let's talk about the future of surgical oncology and the advancements that we're seeing with robotic surgery. Can you explain a little bit more about what that is for our listeners who may not be in that surgical world and how it's being used today?
Certainly. Robotic surgery is also called robotic assisted surgery because the surgeon still controls the robot. And it allows the doctors to perform many types of complex procedures with more precision than they could before. It gives them more flexibility and more control. It's usually a minimally invasive procedure, but there are times when the robot cannot get the tissue that's needed and the doctor has to do an open surgery. The systems usually include a camera and mechanical arms and surgical instruments, and the surgeon sits at a computer console and The nice thing about robotic surgery as opposed to laparoscopic surgery is that you get a magnified 3D view of the site. With laparoscopic surgery, the surgeon only gets a 2D view of the site. So, with this 3D view of the site and the more instruments, the more arms, the surgeon has a greater range of motion and precision. The advantages of robotic surgery are less surgical site infections, less post op pain, less blood loss. So, there's a quicker recovery, and of course, the scars are smaller. However, the risks are similar to conventional surgery. And when you compare a lot of robotic surgery versus laparoscopic surgery, the benefits are small, and robotic surgery is more costly. So that brings up a conversation at times when hospitals are thinking whether or not to buy more robots. But the robots are used for abdominal colorectal surgery, GYN, head and neck surgery where you need a lot of precision, spine, which is very delicate, and urological surgery. The neat thing about robots is their ability to get more skills and enable the doctors to do more than they're doing now. As I said before, sometimes the robot can't get into some difficult spaces, so they have to open the surgery up. The generations of robots that they're working on creating are going to be able to access more difficult spaces. They're going to be more precise. Robots not only give you visual feedback, but they give you tactile feedback. And feedback that you can feel in your fingers, but they also give what's called haptic feedback. Haptic feedback is a type of tactile feedback, but it's feelings we get from joints and muscles and tendons that right now robots are limited in their ability to provide that. Right now, the robots give you 7 degrees more freedom than the human wrist. I thought that was interesting. You can move your wrist 7 degrees more than you can without a robot. We can also add more arms to the robot if needed for more surgery. And they're working on third generation robots. The Da Vinci robots, considered second generation. Third generations have concentric tube devices, and these aim to prevent the lack of force of action at a distance. Right now, sometimes if we're reaching very far into the patient to get something, the force that you're using decreases. But these concentric tubes are being developed to prevent that. They would be considered the third generation robots. Fourth generation, they're working on microdots, which are really fascinating. They're robots at a microscopic level that would be placed in the body and work as a solitary robot, or you could place a group of them to image and treat surgical diseases and manage infective and immune processes. And the fifth generation is what the goal is, I guess, would be autonomous robots. I think that's when we'll see the true value of robots as they learn to use artificial intelligence in order to become autonomous.
That is just amazing and really exciting hearing about all of those generations to come and where cancer surgery is headed in the future. Just exciting things. And like you said, if it can decrease all of those side effects of what we would consider traditional surgery now, and imagine the recovery of patients with these new advancements in robotic surgeries.
Agreed.
Are there any other advancements in surgical oncology in the future that you have heard about or know might be coming down the pike?
I think people are exploring ways to use more chemotherapy, especially heated chemotherapy, as part of surgery, possibly using internal radiation so the patient doesn't have to go through a system afterwards. But mostly, I think what we're looking at is using more precise surgery to get out less tissue to cause less dysfunction and less disfigurement in patients. We have a lot of progress, as I'm sure you're aware, in immunotherapy, and we're developing vaccines, gene therapy, gene editing, and even microbiome treatments that we can use neoadjuvantly so that less surgery is required, when sometimes surgery won't be required at all.
Right. I think that combination therapy and how those changes are happening are pretty amazing as well. If we think back to our earlier conversation of the barbaric surgeries that were done, and it was just open people up and take out whatever tumor there is. And with the evolution of those things, like you've mentioned, the immunotherapy and such, and with those being so precise and sometimes completely getting rid of tumors, and then the need for those invasive surgeries are no longer, or now they're not as invasive because the tumor has shrunk to such a size that maybe the robotic surgery is the option now because it can be so precise because of the size of, what the treated tumor may have been. So it is really exciting hearing all of the advancements in surgery, as well as what that combination therapy has done as well.
Agreed.
So, Deena, it's been so exciting listening to you and hearing about, the history of surgical oncology and where we are now. And I like to finish our podcast every time with, I like to call them my quick fire questions. And I have those for you before we finish up today. And the first one is, what are some common misconceptions about surgical oncology?
I think the common misconceptions about surgical oncology is that you're going to disfigure the patient. Extensive surgery is going to interfere with their ability to live a good quality of life. Some people still believe that surgery will cause the cancer to spread. Some people believe that surgery will always remove all the cancer cells. People have the idea that it can be excruciatingly painful and disfiguring. And we have evolved so much, and our surgery is so minimally invasive in many ways. We talked about breast lumpectomy and versus mastectomy. We can now do for certain cancers sentinel node dissections instead of full axillary dissections or other areas of the body, like with melanoma, so that the patient avoids lymphedema or decreases their chance of lymphedema. So I think that people need to know that surgery is not disfiguring. We have wonderful rehabilitative surgery that just amazes me. I remember growing up and seeing a peer who had had a tumor of his face, and his whole face was deformed. He had no mandible. And now we would take a piece of his fibula, use CT imaging to shape it, and he would look great. We replaced tongues. We can do so much to improve our patients' quality of life, especially when we add in our other disciplines such as physical therapy, occupational therapy, and speech therapy.
Exactly. Thank you. So, what's something about surgical oncology and robotics that's not often discussed, but you wish people knew more about?
I think most of the press for surgical oncology and robotics is positive. However, studies have shown that complications are only slightly less with robotics than laparoscopic. So we don't always need to use robotics in certain cases. Certain cases, laparoscopic is just as good and less costly.
Okay, thank you. So, what additional training or education do oncology nurses need on surgical oncology?
I think the first thing what oncology nurses need is an understanding of cancer basics, just like any oncology nurse. The ONS core curriculum is a wonderful way to start. The ONS Basis in Oncology course and the ONS Surgical Oncology nursing book is great. The problem with books, to be honest, is they cannot be published and updated as fast as we are making advances. So nurses need to make a point of reading journals describing the latest advances, listening to podcasts, webinars, etc. And they need mentoring. You just can't throw a nurse out there and say, take care of our patient. They need to learn how to manage signs and symptoms related to our oncology treatments. So I think whether they're a new grad or just new to oncology, they need a structured preceptorship.
Thank you. Those are definitely important educational pieces for oncology nurses and for those of our listeners who may be new to oncology, maybe new grads, or just wanting to try something different within the oncology specialty and thinking about switching over to surgical oncology. Those are great points and tips. And then lastly, what are some additional resources for patients or providers who want to learn more about surgical oncology?
Well, I've already mentioned the Oncology Nursing Society, which is more or less my go to resource to start with. But the American College of Surgeons has information on cancer surgery. The American Cancer Society is a wonderful resource on cancer treatments, which include surgery. National Comprehensive Cancer Networks has professional guidelines as well as guidelines for patients, which are wonderful and are updated continuously. And though they mostly deal with medical issues, there is a lot of information on surgery and new advances on surgery specific to the disease. Cancer.gov, the National Institute of Health, gives updated information on types of surgery. And finally, ASCO, the American Society of Clinical Oncology, has information for patients and health professionals that is helpful.
Thank you. Well, again, Deena, I just want to thank you so much for joining me today and for all of your expertise and your listening to your passion about surgical oncology. It has been just a really exciting um, discussion that I've had with you today, and I want to thank you for that. Do you have any final comments before we go?
I think anybody listening to this is probably already an oncology nurse. So this may not be directed to them, but people say to me all the time, how can you be an oncology nurse? Isn't it depressing? And I find I learned so much from my patients. And surgical oncology is not depressing much of the time. Of course, when patients die, especially young patients, it's depressing. But usually you get so much, I get so much an intrinsic reward from dealing with these patients that I tell everybody to consider oncology nursing.
Well, thank you so much, and thank you for joining me today.
Yeah, thank you very much.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.